Hello. On behalf of myself and co-authors, I thank the Ideal Collaboration Group and the organizing committee for the privilege to present our work, esteemed members and guests. These are our disclosures. According to the Center of Evidence-Based Medicine, a randomized controlled trial is the best research method for evaluation of any healthcare intervention. However, RCTs in surgery face multiple challenges in comparison to their medical counterpart. As a result, 1 in 5 surgical RCTs are said to have failed to complete, with poor recruitment being the reason half of the time, and majority of the completed ones are of so-so quality with less chance of publication in a high-impact journal. The IDEAL framework introduced by the IDEAL Collaboration in 2009 proposed solutions to these challenges by looking at surgical interventions differently from the medical interventions. It describes 5 stages of evolution of surgical interventions: the idea stage, the development stage, the exploration stage, the assessment stage, and the long-term follow-up stage, therefore providing a pathway for rigorous but stepwise evaluation of new surgical therapeutic interventions. This slide shows a schematic diagram of the 5 stages. Stage 1 is the idea stage. This mainly is the first in human use of the proposed intervention, usually involving one surgeon, 1 or 2 patients, and at a single center. The main and the best way of communication at this stage is a well-written case report describing the intervention in full detail. Stage 2A is the development stage, and at this stage, the intervention is now applied to a few more patients, and a limited number of surgeons may be involved. Usually, though, this is a well-selected group. Modification of the intervention or its indication is common at this stage. These can be communicated through case series with adequate documentation and reporting of the modification with their reasonings and timing. Stage 2B is the exploration stage, and at this stage, large number of patients and surgeons are now involved in the use of the intervention, also at multiple centers. This is where maturity and stability of the intervention occurs. A crucial item at this stage is a prospective and collaborative data collection and multi-center study with the assessment of quality and learning curves of surgeons and pre-planning for a future RCT. Stage 3 is the assessment stage. At this stage, the intervention is now widely accepted and practiced, reaching a state of equipoise. It is where a comparison of the new intervention with the standard intervention through an RCT is more feasible. And finally, stage 4 is the long-term follow-up stage. This is where long-term surveillance of patients is important for detection of late outcomes. It can be achieved through the creation of prospective databases or registries. This slide shows the key recommendations in IDEAL Stage 2B, all of which are working hand in hand to improve the feasibility, quality, and success of a future surgical RCT. Very important is the design of a multi-center cohort study with prospective and collaborative data collection, which provides the opportunity to have a collaborative agreement on the intervention's definition, quality standards, and patient selection criteria. Also examine differential outcomes in pre-specified subgroups, gather data, and calculate power and sample size for future RCT, evaluates learning curve and patient and clinician preference and values, come to an agreement on future RCT questions and best comparator, and finally, design a multi-center randomized trial. Now, whether the recommendations in IDEAL Stage 2B influence surgical RCT positively remains unknown and is therefore the purpose of this study. We hypothesize that having a preceding IDEAL 2B-like study is associated with improved quality and increased chances of high-impact journal publication of a subsequent RCT. The study was designed as a case-control systematic review of the literature. The Prisma diagram here is showing the study plan and flow. In the identification stage, we used pre-specified criteria to identify all surgical RCTs published between the years of 2015 and 2019 in Ovid Medline. As shown in the blue box, Those in high impact journal, meaning impact factor of 5 or higher, are classified as cases, while in the orange box, those in low impact journal, meaning impact factor less than 5, are classified as controls. We screened all the identified RCTs to ensure they meet our eligibility criteria. We used Google Scholar to identify preceding ideal 2B-like studies in the included RCTs, shown in the gray box, and used the Cochrane Risk of Bias Tool 2 to assess their bias risk as a surrogate for quality, shown in the green box. Then, test for the associations between ideal 2B-like studies and increased quality and impact of subsequent RCTs, while adjusting for other covariates. The study is still ongoing, and on this slide is only a preliminary pilot result. To the left is a graph showing the proportion of RCTs in high-impact journal, represented by the blue bar, that has preceding ideal 2B-like studies, compared to those in low-impact journals, represented by the orange bar. As shown, more RCTs in high-impact journal have preceding ideal 2B-like studies. To the right is the risk of bias assessment of 10 RCTs, divided by the purple line. The top 5 are from high-impact journal, and the lower 5 are from low-impact journal. In the black box is the final result. Green circle means low risk of bias, yellow means minor concerns for bias, and red means high risk for bias. As shown, 3 in 5 RCTs in high-impact journal have low risk of bias, while there is only 1 in 5 of RCTs in low-impact journal. Note, this is only a descriptive data, as we are yet to test for associations. To conclude, when the study is completed, we will be able to determine whether the proposition that ideal 2B-like studies can influence the quality and impact of subsequent RCT is supported by the current literature. Here are my references. Thank you, and we will now take any questions.